Well, welcome everybody. Fantastic you could join us to listen to our webinar today and discussing incredibly important topics, which are the resilience of the services, the health and care services as we go into winter. I'm just getting a little bit of feedback, so I'm wondering if Maxine or Victor can just mute whilst I'm speaking. Then great, thank you. So as I say, welcome to join us. My name is Mike Farrar. I was for many years the Chief Executive of a number of NHS organisations, Strategic Health Authorities and the NHS Confederation. Now work independently, and I'm delighted to have an association with Visionable, and we're delighted that they are hosting this webinar for us today. Perhaps a little bit more about that later. But first of all, the sort of topic in question is really, and it is slightly odd that we talk about winter planning still, in a sense where demand has been fairly constant throughout the year, and in fact over sort of recent years with COVID, we have demand coming at us from COVID related pressure, whether that's in primary care or secondary care. We have care services under pressure continuously, and of course the rising demand that we generally see going into winter months really just adds on top of demand that you might argue we've not really properly managed throughout the rest of the year. But the idea of sort of helping us prepare for the next few months is incredibly relevant, I think, and I'm delighted to be joined by two fantastic guests today. We have Maxine Power, who is the Director of Quality Innovation Improvement at North West Ambulance Service, and we have the wonderful Lord Victor Adebowale, who, as many of you will know, has been a non-exec on both NHS England and NHS Improvement, was a fantastic Chief Executive Turning Point, and is also a colleague of mine in terms of Visionable, in terms of his ownership of Visionable, along with others. So we've got a great opportunity now to sort of pick the brains of two really smart people thinking about winter. So I'm going to start with you, Victor. I know you want to kind of set a fairly broad canvas for this discussion. So when you think about what it means to think about resilience through these coming months, what is it that you think are the sort of main problems that we're going to have to deal with? And as you look at it, what are the sort of emerging solutions in your mind that the NHS and care system has got to be ready to adopt pretty quickly as we look forward?
Thanks, Mike. Thanks for doing this, and hi, Maxine. It's good to see you again. So the question is one that's been on my mind for a while. I guess there are a number of sort of conditioned things. First of all, we've learnt to cope with COVID, but it's not entirely over in terms of its impact on the NHS, elective care, staff exhaustion, moral harm, sickness. These things are variable around the country, but it's still there. The second thing is flu. I understand that we're looking at flu cases possibly 10 times what there were last year. Then there's the impact of staffing shortages, which are significant across the NHS. Nurse shortages, I think ambulance also challenging, but also specialist doctors as well. And then we've got the challenge of capital, actually, which is we don't talk about it enough, in my view, which is we are short of the kind of capital that would make the kinds of improvements that we need. So that's the context piece. Then there's the kind of operational piece, for want of a better word, which is we will get through winter. That's not in any doubt. The question is what state we get through winter in, and what it does to our already exhausted staff and overstretched services. My concern is that we are able to provide those services where they are needed most to those people who need them most, in the areas that I've often worked in, which are the areas of high demand because of ill health and the conditions which create ill health, and that we're able to respond to those needs as and when required. And of course, Maxine's service is pretty critical to that. They have been stretched almost beyond belief across the country, and we've seen the impact of that. In addition, and it's rarely talked about, the mental health burden on our emergency services is significant and will increase during winter, and is a major challenge for at both the acute and mental health sectors. Actually, it's just a challenge over time, which works over Christmas. So this is what we need to do. We need to prioritise those services that are front-facing, that are patient, citizen-facing, for want of a better term. We need to ensure they can operate at maximum capacity. We need to remove any constraints on those services being able to operate. We also have a strike. I mean, it's the most obvious thing that we are mentioning, but I know that my colleagues in the NHS will ensure that crisis and emergency services run, but nevertheless, it's part of the contextual piece. We have to remove all constraints on the front line being able to operate. My view, it's a personal view, is that we need to push management and leadership down to the place where it's nearest to the demand, so that we give people maximum control over how they respond to the conditions that they're facing within their services and the conditions that are presented to them, and then support them to do that. Within that, there's the digital piece, and obviously I'm speaking as the chair of Visionable, and we are working with a number of health organisations now in order to ensure that patient citizens get access where they need it most, without them having to go to the system and the system comes to them, and that we can triage as many cases as possible so that we avoid unnecessary ambulatory care. East of England Stroke Network, some of the pilots we're doing with Maxine, designed to give people access to clinical support when they need it most. This is particularly the case actually in things like mental health and stroke. So there's a number of challenges. I'm convinced we'll get through it. I'm concerned about what state we'll be in when we do get through it.
Thanks, Victor. And there's a good groundwork. I'll come to you, Max, because obviously Victor's kind of set out the sort of general major challenges, but that idea of resource to need, you know, from an ambulance trust perspective for yourself, you know, that looks quite a challenge in terms of where do we put the resources versus the need. But just tell us a little bit about, you know, your expectations of the sort of coming period and the kind of things that you're thinking about that the ambulance trust would be needed to help manage that. Hi, Max, I think you're on mute.
Apologies. That's not very good, is it, for a digital focus session, that one of the speakers can't manage to get themselves off mute? Apologies. So yeah, of course I will, Mike. So just to introduce myself, I'm Maxine Power. So I'm the Director of Quality, Innovation and Improvement at the North West Ambulance Service. Proud to be part of the NHS. I've been in the NHS for pretty much all my career. I think I have to say though that this is probably the toughest of times, and I'm eternally grateful to colleagues who every day really are doing their absolute best. So Victor, you talked about, you know, let's get the help to the people that need it the most, and for me that kind of harps back to the NHS constitution. That's what we're about, and I think every day we do that quite successfully. But unfortunately, I think the strain on the system and the people working in it is becoming obviously it's noticeable. I think one of the things for us, Mike, is, you know, the optics of NHS demand are ambulances queuing up outside A&E departments for the most part. So, you know, that's what tends to hit the media. But behind the scenes, if you look at actually sort of some of the underlying issues that we're having to deal with, these are the things that I think as a senior leader in the NHS, I'm trying to think about. So if we think about demand, we've known that demand on NHS services is going to increase since 2010. So if you'll remember, we did some modelling and we had a quality, innovation, productivity and prevention programme that was launched by the then NHS Chief Exec David Nicholson, and at that point we were already identifying a do-nothing position as leaving somewhere in the region of a £35 billion gap in NHS funding. And that was based on, if you think about it, it was based on increased numbers of people living longer, but living longer with chronic disease. It was based on the NHS's, I think, slow rate of adoption of technology and innovation, and the things that we know would make a difference not necessarily happening all the time. And it was based on the fact that really the agenda had to shift from treatment to prevention. And in the course of the last decade, we've made some inroads into that. But I think the last 2 years, 2 to 3 years with COVID has obviously, it's created this kind of strange scenario where we've innovated in some space faster than we've ever innovated before in the digital space, but in some areas we perhaps, you know, not necessarily done what we need to do to switch off some of this demand that we know is there. So I think in a way we're facing a perfect storm. And for us in the ambulance service, we've got, you know, a very simple service really, which is pick the phone up, get me the help I need, and get me the help I need fast. And when that doesn't happen, we have a compact, I think, with both our staff and the general public where people struggle with that. So call demand is a big issue for us, insofar as we know that the numbers of calls coming into 111 and 999 have exponentially risen. Victor's absolutely right. That isn't proportionate across the whole of the NHS. So we know they have risen disproportionately more for patients presenting with mental health conditions, more for patients presenting with frailty, and issues of older age, and more for patients who are ringing us from disadvantaged areas in the country. So we know that this is not an equitable demand pattern. We also know that primary care is struggling to provide the capacity and that's required to meet the demand, and that when primary care starts to struggle, and this is not about you know, this is not about me being critical of primary care, because they are very good colleagues who work really hard, but they are literally overwhelmed, that the rest of the system then starts to wobble a little bit, because what we know is that people seek out healthcare in a way that is very inefficient. So they will make multiple calls to try to get the help they need, and eventually when that fails, they'll turn up at the A&E department. Again, the number of walk-ins, we're talking about ambulances, like my life is ambulance, but the number of walk-ins to A&E departments is at an all-time high, alongside you know, the ambulance arrivals, which actually interestingly are going down, but we still could do more to actually look at some of the variation that exists across the system. So I'll just pause there, Mike, because I'm sure we'll pick up on some of that as we move through.
Yeah, so again, great scene setting from the operational perspectives, and interesting reflection back on where we were some time ago and whether or not we've been able to kind of speed up. I want to move to you again, Victor, and talk about solutions, because I think we've kind of identified four that from your initial contextual piece. One is, how do we align the resource we have to those with greatest need, particularly if for this time we are serious about tackling inequality rather than being rhetorical about it. Second, distributed leadership, you know, to really empower people closer to the patient, the population, which is a major cultural challenge, but something which we've talked a good game on before, etc. The third is, you know, guiding and signposting, making sure it's easier for people to access care at the right points, or indeed to sort of acknowledge where they're going to go to and put our resources where they will access it, which is another way of facing it. And then, of course, fourthly, the opportunity that digital now gives us in a way that perhaps when I was a chief exec and we were reducing waiting times, we had money. Now we seem to have no money, but we do have digital and data to really help us. So when you think about those kind of four solutions, and in a way, digital could well be the platform on which the other solutions could be delivered. What is your view about where we should be really thinking hard now about sort of investing in those solutions as part of these, we're all producing these winter resilience plans. Plans do nothing, actions do a lot. What would you like to see the system do in those areas that we've identified could be the way forward?
So it's interesting, isn't it? Michael Tyson pointed out everybody's got a plan till they get the first punch. Yeah, and the NHS is riddled with plans and punches. I think, look, the first thing we need to do is to make. There's no point. I co-founded a digital platform. I know all that, but I also know that digital without transformation doesn't work. So it's all about people at the end of the day. And if we're going to put in a digital service, a digital platform, then it's only significant if it changes what people actually do. So if it changes what Maxine's colleagues actually do, such that the people that are ringing up with mental health challenges or with strokes or whatever get a service that they need. And so the first thing I would do is make sure that Maxine has the headspace and the resources to design services around the technology. In other words, there are three. I always say this, and forgive me if you've heard this before, Mike, but there are only really three challenges in the NHS: equity, access, and digital. I won't go into them, but if digital isn't helping you with the first two, why are you using it, right? So the first principle is the people that are really up against it, and I think the Northwest, and I'm just about to complete a big piece of work on health equity, health inequality in the Midlands, and I know there are some serious challenges all over the country that are, but there's some real challenges in your patch, Maxine. The key is that you get the resource to actually change the service. So there's no point in just dropping a sort of spot an app or something on you and expecting that to transform the service. It might do a little bit, but really, if you want it to actually work, you need the help to change what you're doing to take full advantage of the opportunity that digital affords you. So I think that's the first thing. Those people that need the support most tend to get it the least when they need it most. So I would say that some resource for transformation services, rapid transformation, rapid learning, rapid spread in those areas of high need seem to me to be pretty mission critical. And I think that needs some flexibility from the centre. I think forcing stuff that's been agreed up there down here doesn't work. It might work for a bit because you've got no choice, but over time, my experience tells me that it becomes less and less functional, and it leads to waste. So my view, it's a partnership. Resource it. Make sure that Maxine and her colleagues get the rapid support to change things quickly and make that service transformation. I think. Secondly, and these aren't in any particular order, but secondly, I think we really need to listen to what Maxine was saying and what we understand about patient flow. At the end of this day, people vote with their feet. You can tell them, efficiency or inefficiency is irrelevant when you're in need. You go to the service that is in front of you. So I think it's really important that you understand the context in which people receive NHS and social care services. And in some places, it is incredibly poor. So one of the things I'm quite keen on is working with those communities before we get to winter, so they understand how to operate when winter comes, in a sense. And actually, they can help us. I mean, I've actually done this in previous hats on, actually helping people design the kinds of responses that work for them in a crisis, so that it's familiar and there's nothing spreads faster than the word of mouth, particularly in poor and stretched communities, when it's coming from the people living those communities, as opposed to places where from people that don't live in those communities. That's the second thing. I think the third piece is the ambulance service technology, current technology. And forgive me, Maxine, if I'm displaying my ignorance. See, you face this every day, but I know that current technology enables ambulances to do a lot more than they used to do. But it does involve changing how paramedics work on site, and you have to work with those people. It has to be useful to them, otherwise it changes. So, for instance, some of the stuff that we're doing in stroke enables people's what's inside your head to be screened directly to the hospital, and for that to be looked at by a specialist, and that specialist can decide there and then whether you're actually having a stroke, and if you are having a stroke, whether it requires thrombolysis or thrombectomy, and if it does require, get the hospital prepared, and a lot can be done before you even get there, which we know has saved lives. And we know that in mental health, interventions that give people direct access to somebody who's going to talk to them and actually tell them what's going to happen and talk to their relatives and get the support and advice, actually can prevent them ending up in the back of the police car and possibly dead, depending on where they are. So these things require shifts in the way we operate and the way we lead. So when I talk about distributive leadership, I don't talk about it as some airy-fairy management theory. This stuff saves lives. This stuff could actually manage demand. And not just during winter, it changes what we do when winter isn't here. This the old saying, isn't it? Winter happens every year. Why is it a crisis, right? So if we put these things in place now, they actually manage demand the whole year. So the winter becomes something that we manage. It's business as usual, and not a crisis.
So Victor, looking through, really helpful and quite provoking there, Max. And I guess looking through the end of the telescope that you look through, and having an incredibly distinguished career around transformation in different sectors, and looking at reducing variability and using data and new technology. When you think about those kind of aspects of applying digital, and supporting frontline staff with more capability, enabling us to sort of direct resources in a direct to sort of need, bringing ourselves to where the patients are. I'm always struck, by the way, that architects who used to build paths in new developments stop building paths straight away, because they realise that where they put the path wasn't where people wanted to walk. And over time, architects have learned to wait and see where people walk and then put the path in. Now, if you take that analogy into our services, with ambulances, if people are going to call ambulances, how do we make those ambulance, that capability of those staff and that vehicle and that technology capable to respond to that need? All of those feel great operational challenges as well as great opportunities. And I'm interested, and I know we're going to hear some of the practical things that you're doing, but what's your take on this ability to really transform a service which can be known to be quite traditional in its way? How are you going about really getting that adoption of these kind of ways of thinking in the ambulance trust?
Thanks, Mike. A fabulous question, and one that we could probably spend about a day discussing, but I'm going to try and be as, me, I'm not known for being concise, but I'm going to try. So the first thing is, I just wanted to pick up on something that Victor had said, which is about capital and about the investment of capital. So the Unified Tech Fund was a brilliant idea. So it brought together by NHS a whole load of different small pots of money into one place. But we need a clear strategy on what the future of capital investment into digital is going to be for the NHS, and we don't have it currently. So we're working on sometimes short, very short time scales for turning round bids into the centre, which are not small amounts of money. And it's a bit of a shifting tide. I understand that that's political, but if we're going to do this, we really do need a plan. The other thing that I would say is that if we're really going to do this, we need to start thinking about building skills around improvement and digital into the workforce in the university sector. So we need to start really early. And what I would say is that some of the people coming out of the training courses now could absolutely knock our socks off. So it needs to not be about wholly focusing on them, but also focusing on people who've been in the system a long time, who are actually in positions of influence. So I know that what we need to do potentially is work at all levels in the system, but my sense is we would go for the frontline staff as they're coming into the system and for senior leaders who actually are the people who can unlock doors. So we're going to hear from Matt and Max, and hopefully you'll see how that's played out in the North West Ambulance Service. So here I am, old croc, sat on the board. What is my job? My job is to open doors for people who are really going to make this happen. And I think in terms of how do we take this to scale? So one of the things that I think is quite interesting in it, it feels quite abstract, but actually it's really important, is that if you look at the NHS is a very traditional organisation in some sense, in that you get a group of people who self-identify as IT or IT and informatics, who don't yet identify as digital. And that actually played out for me on Friday. I was with an ICB on Friday, and I was invited to go and sit at a table that was called ICT. And they sat there, and they were all very senior people, and they were essentially determining the ICB strategy around digital and digital improvement. And I said, well, are we called the right thing? But it hadn't actually occurred to them that in naming themselves ICT, they had named themselves as a 1970s set of senior leaders. So we need to do some reframing. The thing about IT and informatics people is they are incredibly progressive, but their job is to keep systems safe. You know, we've just had one of the biggest cyber attacks on one of our health systems, certainly in my memory, and that has created, I think, a renewed sense that first and foremost, we have to be safe. So, you know, all of the progressive work we've done around interoperability, we have to relook at with that, with those glasses on. They don't necessarily have the kind of change skills that you would expect to see in clinical staff at the front line. So they've not been schooled in the model for improvement, in collaborative working, in testing changes, but they have got really good programme and project management skills. So they'll bring over the line a £6 million telephony replacement project, but they'll do it in a specific way. So what we've done essentially is said, right, you've got those skills, and the improvement people who've been working on pathway redesign and developing new systems and processes for clinical care, you tend to be seen by these individuals as quite maverick. You tend to be seen as people who are too high risk for us to be associated with. And what we've actually done is we've brought them together into one team and said, you guys have to work together, find a way to redesign. But the guiding principle has to be, how do we get to yes? How do we get to yes? That's the thing. You can't be saying, we're not doing that because you will expose our system. Similarly, you can't be saying they're not playing with us because. So some of this is really cultural, about making sure we've got improvement people and technical people working together to effect change. And we're doing this all the time. So we're doing it on you know, the basics of the basics, like I've just said, the new phone system, but we're also doing it on developmental work, artificial intelligence, using drones out in the field to actually deploy essential pieces of kit. So there's this whole piece of work. But back to where we are in terms of winter and demand. So for me, there are two big jobs. There's making the most of what we've got, because we've actually got quite a lot. So are we as efficient as we need to be with the money we've got? And the answer to that is absolutely not. So we've got some systems in the NHS at the moment that need a very, very good look. One of them is referrals from one service to another. So a paramedic can spend half an hour on scene trying to get through to a GP. So one of the things we're trying to do is shorten that time by digital referral. And the second thing is we are spending too much time waiting. So those two things really are a big focus. And I can see Mike wants me to shut up, so I'm going to mute to myself.
I was doing my best to be polite, but kind of give you signals, Matt. That I could listen to you all day, you know that. But I do want to bring in Matt and Max and give us this kind of sense in practice, because we want people listening to this to really get that sense of there is things that are immediately possible. So Matt and Max, I wonder if you can join us. Here we go. Hi, Max. There we go. Might just unless Matt can join. Oh, here's Matt as well. So listen, you guys are just going to take us through a very practical example of what you're doing there, and then I'm going to come back to Max and Victor perhaps with some questions. So if people haven't had a chance and want to put anything in the chat or whatever, put your questions in. Otherwise, I'll pick up the conversation again with Matt. So Max and Matt, over to you.
Okay, so I'll do a quick introduction. So Max Hughes, I'm the CCIO, so Chief Clinical Information Officer at NWAS. This is week 3 in the trust, so I'm actually new to the organisation, so it's nice to be here really. So I've had a bit of a crash course in the last couple of weeks of all the projects that are going on, and there's a lot, is the honest answer. So, I mean, one of the things that was, that's just gone live, to, that actually make a difference to people right now is our Director of Service team. So the Director of Service essentially is like, listing the appropriate places where patients can be referred into. That's just had an update last week, where previously it was giving the directions to the nearest appropriate sites as the crow flies, not as road directions. So particularly around bodies of water like Morecambe Bay, or when there's river crossings, it might say, oh, go to this urgent care centre, it's 3 miles away. Actually, it's 9 miles away. But, it was not necessarily listing things in the right order. And also, patients disengage from that because we are telling them it's 3 miles away. They know it's not great. So that's something that's gone in live literally last week and appears to all be working great. So, that will hopefully roll out nationally in the near future. There's all sorts of projects that we've got on the go, stuff around interoperability, about actually trying to make sure that we increase efficiencies, handing over from like 111 to 999 if you need to book an ambulance, making that process as efficient as possible. Simple things like we have an application that was built in-house here called SafeCheck, which is essentially the checklist that the ambulance crew used to have to do at the start of their shift, checking all the equipment's there, checking everything's safe. That was digitized during COVID. But we're doing a version 2 of that at the moment, which is actually removing unnecessary steps and any duplicate questions that previously existed. So we're trying to, adapt that and improve the actual processes now. Because one thing that was mentioned there is that, yes, digital solutions alone are never going to be an option for anything. That's not the way to fix things. It's about having digitally enabled transformation and changing what we do with digital in mind so we can facilitate that. Just giving someone an app or putting in a piece of IT technology isn't the answer. It's about that collaborative working with the people and actually making sure what we do is as efficient as possible. And then where possible, let's use some digital stuff to make that better. We have an entire phase 2 of our EPR will be going live in the new year. So the whole application has been redeveloped as a progressive web app, because at the moment we use some Windows-based tablets called GTACs. They're a little bit old now. Sometimes you have to click the screen multiple times to get things to actually register. With the new web app, we'll be able to move over onto the iPads, and it's a much more responsive, much easier to use interface then. So that'll be going live in the new year. All these are just little things that will make the experience for staff and patients better, as well as laying some foundations for much cleverer things we'll be able to do down the line. So I think we mentioned we were going to be working on a national pilot for fall referrals, so we can refer in electronically, not having to spend time on phone calls. And there's all sorts of projects working on things to do with medicines management and smart screens that we've got in the stations now, where all the information's there, right in front of you. You don't have to go look at multiple paper boards that go out of date. And obviously we've got some interesting stuff to do with smart stations and things like that, which Matt can talk about as well. There's a lot going on, and we can talk about it for hours, I'm sure. And I've only been here 2 weeks, and that's all the stuff that we're working on at the minute. And I've got loads more ideas as well. I spent some time out on a shift with the Salford crew, so I was with them for 13 hours, and you see, bits where you think, oh, I wonder if that could be improved. What could we do to make that a bit better? So yeah, there's lots going on.
Thank you, Matt. You want to add to this?
Yeah, thanks. So I'm Matt Dugdale. I'm head of clinical and digital innovation here at NWAS. So paramedic by background, and I've got quite an exciting role. It's quite a good thing that I'm saying that myself, but I was given kind of a remit with a kind of ring-fenced protected time to look at really exploring new ways of working for our staff and where digital could make a difference. So as Max touched on, one of the main projects I've been leading on is around the SMART program of works. So sort of around 2 years ago now, we spent a lot of time looking at how we could make processes easier for our staff. So as we've touched on this discussion already, life is really challenging at the minute, and staff, they don't just leave all the personal lives at home. They come to work with a lot of stress and additional issues as well. So it's about how do we make their shift, the processes that they need to follow are as straightforward and as seamless as possible. So the first area of focus for us was around our stations. So when they first come onto shift and visit the station, how do we improve the efficiency of that? And more latterly, we're looking at the vehicles and how we improve the processes with our vehicles. So, for example, with the smart station, right back at the beginning, we spent a lot of time with staff understanding the processes that they follow, and we identified quite significant areas of wastage within those processes. So, for example, when they came on at the start of the shift, they'd spend around 45-60 seconds remembering the code for the station, spending another 3.5-4 minutes finding out were, so something quite critical, but also quite dynamic in terms of the picture changing. They were kind of walking around the station asking, has it been a busy shift? How busy are the hospitals? But we know that picture changes, by the second. So they would look at, some of the static wall boards and content, but that often had outdated information that somebody had printed off. They'd again be looking in the key cabinet to find out what keys were available for vehicles. Again, all this was starting to add up, to 10-15 minutes of time that really could be avoided and put into delivering patient care or having more meaningful conversations with their managers. So what we wanted to do was look at testing and incubating different pieces of technology, and some of that we developed in-house. So we're fortunate enough to have a development resource and a development team internally, but also working with some of our industry partners to look at solutions that either might work off the shelf or might need some adaptation to work within the ambulance service. So one of those areas that we're quite proud of is our digital wall boards. So we don't have any paper notice boards across the stations, and as a staff member comes on at the start of their shift, they're able to sign on to those wall boards, and they get an aggregated feed of information. So who they're working with, what vehicles are available and are in service, how busy the hospitals are, how busy the local acute visiting schemes are, so that they've got that real picture at the start of the shift. And that's a solution that we worked on with Sony, but we developed the software, so it was custom built for our staff, working alongside them in a co-design framework to really make sure that was delivering the information that they needed at the start of the shift. And obviously, as I touched on, that's a dynamic picture which changes. Acute visiting schemes change in terms of demand throughout the day. Likewise, as we know, the emergency departments do. So we're spending some time building that as an application that can be deployed to our iPads. So again, we're quite fortunate that our staff have these personal issue devices. So how do we make the most of that? Well, giving them access to this information on the go will help to improve that picture. So they're always in the know in a more dynamic model.
Excellent. So Max and Matt, thank you for giving us that kind of sense of the practicalities of what could be done. And obviously one of the things that I will say, probably hard for Vic to say, but is that in order to be able to have confidence, the quality and the reliability of our technology to support those processes is hugely important, and the trust that you have in your partnerships, both internal and external. And obviously from a Visionable perspective, clearly, this relationship with NWAS is one that, people are looking to support, develop, but not just in the Northwest, of course, sort of bringing that kind of quality and reliability into the health and care system at scale and at pace is something that is absolutely fundamental. So I'm just going to sort of just check with Elaine in terms of any sort of points or questions from our participants and people listening. Elaine, is there anything in the sort of chat there that you think we should be sort of putting to our colleagues whilst we've got them?
There are quite a number of questions, and we might not have time for them all, but let's try a couple. So the first question coming through is that it sounds like NWAS are quite advanced in their technology use, and they're asking, are they mavericks, or is this happening in all trusts? And how far away are we from seeing this level of digital technology becoming commonplace in the NHS? So that's the first question.
Brilliant. Maxine, it's not about you being maverick, because we know the answer to that already. This is about the Ambulance Trust. Yeah, great question. Max, quick answer, then we can get a few more questions in.
I think we are seen to be on the more progressive end of innovation. What we have tried to do, though, is balance that with making sure that business as usual is not ignored or in any way kind of undervalued. But yeah, I think we are progressive. I think certainly the work Matt's done has received quite a lot of attention from other ambulance services, and it's like everything. I think it'll be the rate of adoption that will define whether or not we see a sustainable ambulance service into the next decade.
Thanks, Victor. You work, I know, through Visionable with a number of ambulance trusts. The Northwest at the leading edge?
Yeah, I'd say it's one of the. I mean, I'm not going to say it isn't. Am I? It's a fantastic service. I've seen Maxine walk across Lake Windermere. Now, I think it's one of a number. I think my view of this is that it's about thinking long. Where do you want to get to, and learning short. You know, and Matt and Max's work is really critical to that, because it's not as though you do this and then stop. You've got to consistently learn and keep genuinely rapid. It's rapid learning. That's the key. And Matt's work is really taking out negative value transfer. You know, you're looking at working with the people who are actually in the work. And being curious with them is what drives the change. So I wouldn't call it maverick. I don't think, you know, I would call it good leadership, strong management, and a clear vision of where you're going to go, and learn on the way, and then share that learning with as many people as possible.
Brilliant. I'm going to come to next one, Elaine.
We have a question just when, Matt, you were talking about staff pressures. Someone's asking, they've started a campaign offering electrical bike solutions to the NHS for staffing to ease personal financial pressures, increase staff retention. They're asking if you think this service could also be used in the field to deliver patient care rather than using motor vehicles, obviously only in certain situations.
Yeah, so we do have 2 cycle responders at the moment. It's generally the response model for cycles works quite well within urban areas, just because of the you know, where there's high footfall. So we have those in Manchester city centre, and they do work quite well. And at seasonal times, we'll put them into different areas. So Blackpool, for example, during the summer, sometimes when there's high footfall, we'll utilise cycle responders. Similarly, in other trusts like at Heathrow, they have about 5 or 6 cycle responders, you know, where they've got that high footfall and it's easier to get around on a bicycle. So we do look at a number of options, and along the kind of eco-friendly route, we're one of the first to roll out fully electric rapid response vehicles, and there's a lot of work in the space of electric vehicles, as in ambulances at the minute as well, which we're monitoring quite closely. So yeah, I definitely think it's a great idea, and I think we do have something similar for staff that want to sign up to the Cycle to Work scheme, but I'm not quite sure how popular that is at the moment.
Thanks, Matt. Elaine, we got next one.
Let's go for a final question before we let you wrap up, Mike. Should the plan be to start in the community, so in care homes and in secondary care? This would be a great baseline. That's the question.
Okay, well, that's Victor. You have a huge whole system view.
My view is, yeah. I mean, I think it's different. It's different in different communities, but unless you understand the community, you don't know, do you? And I think it's really important that we understand that's what population health is fundamentally about, what ICBs and ICSs should be doing. And we are learning to be better at it. I mean, there are 4 rules of community engagement. You've got to listen. You've got to hand power. You've got to give people power so that people can do something during or after the engagement they couldn't do before. You've got to do more than co-production. You've actually got to design for with the people who are going to be using the service most. And then finally, the end result has to be usable. I mean, there's a reason why people go to A&E. They go to A&E because they understand it, right? So whatever you do, it's got to be doing. So I think that's where you've got to start. Different communities have different configurations. From Visionable's point of view, we're working obviously with ambulance services, but also working with colleagues in care homes as well, because a single platform can connect all of them with the health and care system. So you're bringing the system to the patient. But I'm a real passionate advocate for understanding the communities that you're providing a service to, because if if you don't, then you don't know what you're doing, really.
Thanks, Victor. And I'm mindful of fantastic piece of work that Brenny Brown's done, if you haven't seen it, where she taught in response to the Black Lives Matters work and said, actually, although we think we can walk in other people's shoes, you can't, because when you put those shoes on, you have a different experience to that point, so you walk differently. And what she said was, we just need to learn to listen better and believe, which I thought was really quite profound.
I think that's very powerful, Mike. It's very powerful and true.
Max, last thought on this one?
Yeah, a couple of things spring to mind. So I think as healthcare professionals, we think of healthcare systems, and I think for me, I have to completely keep resetting. We should start with health, not healthcare. So how can we work with communities on community health and resilience? And then obviously the conversations will fall out of that around healthcare, but I think perhaps we've got to reset that focus continually. We have 1,000 volunteers in NWAS called Community First Responders, and they are incredible. They are absolutely incredible. They're deeply embedded in their communities, and they are every day doing work in schools, in education settings to actually help people to respond in emergency situations. But I think they can do more, and that's what we are trying over the winter. I think the thing I'm increasingly saying is the ambulance service is a primary care service, and out of hospital care is actually the escape fire for the NHS. If we could get people to pay more attention to the integrated out of hospital setting, I think we would be in a very strong position, but we keep being drawn to hospitals. And finally, to the person who asked the question about cycles and electric cycles, absolutely. However, we must look at that variation that we've got, because actually, if you can use digital technology to manage somebody's condition at the point of call without having to transport yourself to them, that is the most efficient of all. That is the most green of all, and that is the way we should be looking at our work into the future.
Yeah. Thanks, Max. It was a point that I was going to come into part of the summary, which is such is the power of the acute landscape and the acute lens that we've looked at the ambulance to hospital boundary rather than the patient to ambulance boundary in terms of thinking about where technology could be really helpful. Elaine, I know we're going to finish shortly. You have a poll to launch, I think, before we finish. Yeah. So what we would like you to do is just to let us know if you would like any further help from Visionable to discuss what we've talked about. You know, we're very conscious that this is not a sales pitch. This is about thought leadership and really thinking how we can transform services. But obviously, if you do want to follow up with anybody from the Visionable team, and I think Victor's point about how Visionable works completely across sector, including with ambulances, but into care, primary care, secondary care, etc., and even sort of rehabilitation, post-stroke, etc. There's a huge amount of opportunities, I think, that Visionable will be happy to support people on. So if you can let us know that, that would be really helpful. Thank you for that. So I'm just going to round up. I'm going to thank Matt and Max. Thank you so much for joining us. Obviously, thank you to Maxine and to Victor. As always, there would have been so much more that had I been a better chair and we'd had more time that we could have understood from the wisdom that you bring. The one thing that I will, and I continue to take away this kind of thought from these roundtables, which Visionable and other organisations have been sponsoring to try and get really people thinking about their work, not just doing the work, but thinking about how they could do it better, is that there are kind of three levels here. We have to have real vision, and that requires people to lift their heads from the operational to see what's out there. But in that vision, we also need the business case for change. And a lot of leaders at the moment are so heads down that they can't really sort of see the opportunity to understand how technology can help. We then need good quality technology, but speaking to both Victor and to Maxine's point, technology alone does nothing. It's technology and transformation that really make the difference. And so thinking about how you apply these mechanisms, which do require change to what we've always done, and resourcing that properly. We talked about capital, for example, being a real point that kind of helps us with this. And then the final level at which we need to work is this idea of a mindset, which is why are we doing what we're currently doing as opposed to doing something different. And a lot of that comes back to the quality of the leadership, and by that I mean Victor's distributed leadership point about seeing the world differently. And if there was ever an example that I think we've given today, is that if you think your job is IM&T, what does that tell us about or ICT, about the mindset that you bring to the job, as opposed to thinking your job is about digital transformation, where you are actually able to see yourself as part of a huge approach to change, as opposed to someone that is actually, you know, about kit or whatever. So thank you again to everybody for joining us this lunchtime. I know this will be made available and published on the sort of websites, and people can see that at their leisure, but thank you if you've joined us from your busy operational lives. I certainly know my 4 guests have done that, so thank you very much to yourselves, and hopefully we'll see you again in the future when we're running more thought leadership from Visionable. Thank you very much indeed, everybody. Take care.
Thank you.